Welcome to this CYP IAPT What's Next planning event. I'm going to start, do a bit of introduction to sort of set the scene. Alex is going to follow on and sort of, I think we'll be emphasizing points that we want you to take away with. So for those of you who don't know me, I think I've met all of you pretty much. I'm Duncan Law. I'm the clinical lead for CYP IAPT for the London and South East Learning Collaborative, and also part of the Hertfordshire Wave 1 site, and I'll be saying a little bit more with my Hertfordshire hat on later. But in terms, so I just want to start by setting some key themes around CAMS. These are things that hopefully you'll already be aware of. This is the depressing bit. So we're going to start with the depressing bit and it'll get on to the more hopeful bit, we hope. So some facts about CAMS. This is the one we all know and gets quoted widely. 1 in 10 children in the UK have a mental health problem. This is unlikely to be true. It's likely to be a massive underestimate. And it's an underestimate because of these things. So the figure is often misquoted. It really is only about kids between 5 and 16, and yet it kind of gets put together as if it means all kids under 18. And what we do know is that post-16 you see a sort of real sharp increase in mental health problems from 16 to 18. Also, it's very old data. It's data that started being collected last century. And was reported on in 2004. So even when it was since it was reported on to now, it's already 10 years old. And we know there's never been a sort of quite the same look at prevalence data. But what we do know is where we've had snapshot looks at prevalence, that there is an increase in mental health. What we know is particularly around ADHD and self-harm. And I think going round, this is our kind of clinical experience on the ground, so that mental health problems are increasing, referral rates are increasing, but even where they're not increasing, the complexity and severity of difficulties coming into services are certainly becoming more tricky. And this is also a snapshot, so this is only at any one time in the UK, 1 in 10 kids between 5 and 16 likely to have a serious mental health problem, diagnosable mental health problem. That doesn't account for the change over the course of a year. So in the course of a year, again, it's much more than 1 in 10. And I think we just need to be kind of mindful of this, and particularly when we're talking to commissioners. Out of the same sort of lot of data came questions about, well, okay, if these 1 in 10 or more than 1 in 10 have mental health problems, how many are actually accessing services? And in adult services, it's about 35% who don't access services. So 35% of adults with serious mental health problems don't get access to specialist mental health services. For kids, 5 to 15-year-olds, that's a massive 76%. Now this is old data, so we think that this is likely to have changed, but we don't know how much it's changed, and it certainly won't have changed massively from those figures. So the most kids, it's still probably true, who have a diagnosable mental health problem don't come into contact with our services. The other bit worth bearing in mind, again, this might be familiar data, is around where mental health problems, lifelong mental health problems start. For half of lifelong mental health problems, they start before people are 14. And by the time people are 25, 75% of lifelong mental health problems have begun. So we all know this because we all work in child mental health services, is that if you can intervene early and stop these problems becoming lifelong problems, you not only save a fortune down the line, but more importantly, you save all the distress and human misery of having a lifelong mental health problem. This is just another way of showing that data, but comparing it to physical health problems. So the yellow band here is onset of lifelong mental health problems. All the other colours are onset of lifelong physical health problems. And what you'll see is under the age of 25. The vast majority of lifelong, the start of lifelong problems are mental health by a mile. So compared to physical health problems, mental health problems are by far the most serious problem for young people. So you'd expect, wouldn't you, given that data, that the money would follow that, knowing that most mental health problems, lifelong mental health problems, start before the age of 25, and knowing that mental health problems are the biggest problem in terms of lifelong prevalence, start with the under 25 age group, you'd expect that health economists would be wise to this and would be advising the government to pump money into children, young people. And yet this isn't true. The best figures are that 6% of mental health funding goes at services aimed at children, only 6%. And it gets worse because Young Minds did their Freedom of Information Act request over the last 18 months or so, and they found that services are still being cut. So we only get 6% and the services are still being cut. And there are some shocking figures in there, like some local authorities are cutting their mental health spend by 95%. So we are in underfunded services, under-resourced services, where the resources are shrinking rather than growing. So we're under-resourced. We know that there's a Tier 4 beds crisis. This is the other part of the context. Best estimates are that half of those Tier 4 beds are filled with adolescents with eating disorders. So that's the depressing bit. Okay, depressing bit over. That's the stuff we all know already, but I think it's important for us to know, and I think it's important that we kind of communicate this kind of data to commissioners, because they're the ones who really make a difference. But there are opportunities. There is an interest in child mental health like never before, and also there's an election coming up, and I think that is in our favour and we can monopolise on that. So there's the recent CAMS Select Committee, which is just finishing now and will be reporting, and on the back of that was the Child Mental Health Task Force that's being set up, which is being asked to report on CAMS in a very tight timescale. But all these things will really give us an opportunity to monopolise on what we would all want, I'm sure, which is to have services that are better resourced and services where the small resource that we have are well focused. But there is a threat to all this, and it's the threat of poor data. Data is a real issue for mental health services. How we measure the quality of what we do is more difficult than it is for physical health services. So the best example is oncology, cancer services. They measure their outcomes by if someone's alive 5 years after a diagnosis. Fairly straightforward thing to measure about whether someone's alive and how long 5 years is from the diagnosis. What we do is much more complicated to measure whether someone is well or not, and how much movement they've made towards that. So what we're doing is more difficult. There's no doubt about it. But if we don't do it, then we are fighting for resources with physical health services who are much better at it than we are in terms of arguing their case. And if we want to monopolise on these opportunities, we have to really work hard at finding ways to argue our case, and data is our friend, and I think we need to be very mindful of that. Okay, this is an event for Tier 1 IAPT services, so for those of us who, we started this a long time ago, and thought it might be helpful just to do a quick reminder of what CYP IAPT actually is. I think it's not changed, but I think the principles have become clearer since we all started 3 years ago. So here's a reminder. And I think it's helpful to focus on the principles, because I think what also happens over time is that the principles get lost and IAPT becomes procedural, just about practice. So it becomes about filling out forms, it becomes about sending people on training, it becomes procedures of getting backfill in place and juggling budgets. That's all true, it is all those things, but it's all those things, those are a means to an end. And the ends that we're aiming for are these set of principles. So, first one is about better evidence-based practice. So how do we embed and use the best evidence that's out there in order to make sure that the kids that we see are getting the stuff that's more likely to work? And this doesn't mean just about the sort of wholesale application of nice guidelines into services. That's not what evidence-based practice is. But it's about drawing on that evidence, using it to fit with the children and the young people that we see and the particular context that they're in, coming up with agreed goals to work on. And if you get those things right, then you're starting to do evidence-based practice. So the second principle is around better collaborative practice. Not because it's a nice thing to do, although it is, but also because it's an evidence-based thing to do. That we know that if you can get really good agreed treatment goals at the beginning of an intervention, then you're likely to get better and quicker outcomes. And perhaps more importantly, or as importantly, young people and families say that this is what they want. They want, quite rightly, to be part of their decisions about their care, about the interventions that they're part of. And because what we do know with mental health, very different from physical health, that you have to work in partnership for it to work. If you're not working in a collaborative partnership, then it doesn't work and you don't get the outcomes. Following on from that, a step on from better collaboration is about authentic participation. So making sure that young people and families' voices are actually making a difference, that they're heard, and those voices that are being heard are actually making a difference to the way that services develop. And making sure that we keep a track and measure and show that what we're doing has some sort of effect, whether it's good or bad. Because we'll know that there are some interventions that we do that will not have good effects. There are very likely to be interventions that we're doing that are harmful and having negative effects. But the majority of what we do will probably be getting good outcomes and be really helpful. But we don't know. We don't know for sure which one's which. We can draw on randomized control trials and get a pretty good idea, but in terms of real-world CAM settings, to collect the data which will tell us what we do well and where we need to improve, that's stuff that we really need to work on. And the outcomes monitoring, the better collaborative practice, the evidence-based stuff, those are the things that we want to kind of particularly focus on today. And if we get all that right, then we can use the limited resources that we've got in the most effective way. Because if you're under-resourced, you have to make sure that you're using your resources to the best available way. This is just to show you that those things are not discrete, that there is overlap between each of those principles. So good evidence-based practice means young people participating in the room, actually in the clinic room. Better collaborative practice, you can measure outcomes that are around better collaborative practice. This is stuff I hope that everybody should know, but maybe it's always helpful to have a reminder. Okay, I'm going to say the same thing again. I'm going to say this 3 times. So I've said it twice. I'm going to say it one more time in a slightly different way. And this is a slide nicked from Peter Fonagy. So this is saying, right, this is the research evidence. This is all the stuff in the NICE guidelines and other good research evidence. It doesn't work on its own. If you just apply manualized interventions on their own without any mind to the particular young person that you're seeing, you are not likely to get good outcomes. But if you draw on that research evidence and think about how it best fits with the young person or family that's in front of you, and you understand what their preferences are, what their values are, what their understanding of mental health is, what their unique context is. If you can put those two things together, then you're starting to do evidence-based practice, and you're likely to get better and quicker outcomes. Now, that is not an easy thing to do. It's easy for me to say, all you have to do is draw on the evidence, put it together with the needs and wishes of the family, and you're doing evidence-based practice. The reason that clinicians are highly paid is because they bring a huge amount of expertise around putting those two things together. And it's putting those two things together that is proper, in my mind anyway, proper evidence-based practice. So you get it right from the start, you understand what direction you need to head in. But the other thing you need to do is to make sure that there are kind of good feedback loops throughout the intervention between the family and the clinician. So we might have agreed where we want to start off, and we might agree the direction that we want to head in, but as we know, therapy has many twists and turns in it, and so along the way we need to know that we are actually continuing to head in the direction that we all want to head in. And in order to do that, the evidence suggests that as clinicians we need help. Some clinicians are extremely good at it, but the best evidence I've seen suggests that those are extremely rare, those clinicians. Most of us need help to make sure that we are on track and help to have the conversations that we need to have with young people and families. And that's where some of the tools and measures come in to help those conversations. And if you can get that bit right, if you can use the tools in a collaborative way with children and young people and families, and that they're used effectively, then you improve your clinical practice, and you get the data that you need in order to be able to sort of argue for more resources. And the afternoon pretty much is around planning for how those two things go together. Okay, but it's not an easy thing to do. We know that implementing these ideas are not straightforward. So part of the afternoon is to give you a chance to think about, well, what are the next steps in terms of implementing some of this stuff? These are what we're talking about when we're talking about forms. Some people call them ROMs, PROMs, PREMs, feedback and outcomes forms, whatever you like. The language isn't important. It's the effective use of them that actually matters. I won't go into this. Suffice it to say that there is evidence that says that these things are likely to work. But we also need to be mindful about how we apply these in real-world settings. And that's worth noting. And I think others may get into this in more detail, so I'll just say this very quickly. In terms of how the feedback forms are structured, so there's a big toolkit. For those of you who've seen it, I hope you've all seen it, it's quite big, and clinicians say when we see it for the first time, it feels really daunting because there's so much in there. The idea is that it's helpful to have so much in there because it allows clinicians to have and young people to have choice about which are the right kind of forms or tools that fit best for them and their way of working. If we just had one and said everyone has to use this one, that would not have been good collaborative practice, and we would imagine that the data that came out the other end is not likely to be good. But I think that we know that there are services where the sort of one tool has been mandated. And I think we need to kind of think carefully about that. Is it helpful? If it is helpful, then how do we explain this to families in a way that actually makes sense to them? For clinicians, the toolkit's organised in this way. So there's a set of 6 questions which we think are helpful, and the tools might help facilitate answers to these questions. And these are questions which we think are useful to ask regardless of the therapeutic model that you're using, regardless of the problem that you're facing, and regardless of the kind of context that the family and the young people bring. So one is about what's the problem, what's got you here in the first place. And there are tools to help with those kind of questions around assessment. And the second question is, what do you want to change? Sometimes it's just the flip side of the what's the problem coin, but usually it's much more complicated than that. So what the problem that got you through the door is often quite different from the thing that you actually want to work on to change. So that's at the start of an intervention. As the intervention is ongoing, thinking about how we're getting on together. Are we working together in the best possible way? And again, there are tools there to support those kind of and facilitate those questions. And how are things going? Are things heading in a direction that we can both agree on? Are things getting better or not? Or at least are they heading in a direction that we would expect? And also tools to help at the end of the intervention in terms of have we done as much as we can or need to? Have we, it's often difficult for services to let young people go. We know we have conversations with young people who say, I kept going back because I kept being invited, but actually I didn't want to go back for months. I felt things were fine, or I'd been helped as much as I could from this place, but they kept offering me appointments because I kept going back. And then finally, sort of a review of the experience more broadly. So at the end of an intervention, thinking about how was this experience generally. And that's more of a learning for the organisation to think, well, okay, if we can collect a lot of information about young people's experience of our service, we'll get to know the things that we do well and the things that we do less well, and improve the things that we do less well, hopefully with input from young people and people who have experience of using the service. And you'll get a copy of these slides, and just to say there are some resources out there that can help. So here's a guide which be helpful to look at. There's some hard copies of these being printed as we speak, but this is all available online, and fantastic resources on each of these websites. So